everyone, thank you for coming. And again, sorry for starting a few minutes late. We're honored to have Dr. Galvez, who is a graduate of Diablo Valley College and went on to UC Berkeley and then did some research at UCSF and went to medical school at Stanford and subsequent residency at Stanford University in plastic surgery, and then did two fellowships in hand surgery and pediatric hand surgery. And it's someone that not only uh, we're honored to have today, um, but is someone that I could also call a friend. So without further ado, and we'll, glad that he's able to join us today.
Thank you so much. Thank you for the time, and thank you for everybody who stayed and waiting. So I'm going to go ahead and share my screen. This is a long presentation. It's a bit of a whirlwind, but hopefully it makes sense. And so the title is called Trajectory Up. I talk about this all the time. Trajectory means, you're throwing something in the air, it's going up, 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 and you're watching it slowly getting higher and higher. And that's kind of the goal in your pathways. You want to just be going up and building slowly. And that takes it takes time and effort. And so you want to get to where you want to go, and that requires not just checking your boxes, but also thinking ahead so that you can get what your dream is. And so I'm going to go through my story. I'm going to go through mentorship, and some of it's kind of high level. Some of the stuff I've presented to residency programs. And then I'm going to talk about National Latino Physician Day. I'm going to talk about access to hand care, which is a big problem in the United States, as there are a lot of big problems in the United States in regards to medical care. Some people get really good care and some people get no care, which means some people get top tier care and some people get sometimes worse care compared to a third world country. And then I'm going to talk about hand surgery. Hopefully that's a little bit more fun. And so I like to tell families that I went to 30th grade, so 18 years of training after high school. So if you think community college is long, there's a lot more to go. And I went to community college and did terrible at Berkeley. It was the hardest thing I've ever done. And it's not to discourage you, it's just to know that those UCs are very challenging and you have to really take it slow. Do not start your UC like you're just doing community college classes. I was discouraged from specializing. I was encouraged to do primary care as a Latino. And I was even discouraged to take the current job that I have because it's not academic enough, meaning it's not something that is, prestigious, right? And so that's where we have many underserved patient populations across California, across the United States. And so that's where I invite you to think differently. And so I'm currently at my dream job at Valley Children's. I actually just told somebody this today, another employee from here, and I say it all the time because it's true. Are there challenges at any job? Yeah. But it is exactly what I wanted to do because this is me as a medical student, and I was working with all Latino kids in Bolivia and La Paz with hand problems, and that's what I do now full time. So that's pretty cool to be like, I want to do this job. I want to help kids. And now that's what I do fully. And not only do I do it fully, but I do a good job. And the reason I say this, and I say this, it took me about 5 years to have enough confidence to say this. It's just I have good outcomes. I take the time to do a good job. And I don't rush patients through. I like to connect them fully. And you'll see why that is. And it's not to pat myself on the back, and it's with a lot of resources, but that's my goal. And so for me, healthcare, I grew up without health insurance. My parents are from Peru, from Lima. But we were lucky. We were actually privileged because my grandfather was a pediatric surgeon in Peru. So when we would get sick, they would prescribe antibiotics you can get from El Mercado, Mexican markets under the table. I remember falling on my wrist once, and like I couldn't go to the ER because my parents were like, just wait a few days, let's see what happens. And then my interest in medicine has always been rooted to access in medicine because it's always been a problem. When I started as a pre-med student back in 2000, these same issues were to light. A single payer system, no healthcare insurances. Those are things that I was really passionate about. And I still am 20 years, 24 years later. I still am like, what are we doing? How can I not be able to send a patient over here because of an access barrier? Literally, I try to send patients to another place for whatever reason, and they cannot be seen because of health insurance. That is a barrier to care. And there's a lot of barriers. And I encourage you all to learn about them, because if you don't, and you think this is a magical place with unicorns, you're going to be unhappy in medicine. There's a lot of challenges. And then free clinics and Operation Access, which provides surgeries for people that don't have health insurance. And so for me, it's all about I just posted earlier today, just my thoughts actually exactly about this is like, make sure you learn the healthcare system, right? For me, it's a personal, I think healthcare is a right. I think the United States has made a huge mistake in its pathway to a business model in healthcare. And I thought during my training that this access to care would improve, but it hasn't. It's worsened. Sure, we have Obamacare, but we still have. I had a patient, a child whose fingers are stuck together, and they could not see me because of health insurance reasons. Like that is, and it's not, and it's just challenging, right? And it's not. My hospital does an incredible job of getting patients in and trying to connect them, and get all these boxes checked, but a barrier will stop a family. They'll be like, "Oh, I don't want to do it this year. I have to wait for my premium to go down. Maybe I'll do it next year." And that delays cares for kids, care for a kid, not cares for a kid. And there's global need, and some people like, I want to go to this other country and do this amazing work because they don't have any care. But guess what? If you drive 3 hours from a hospital anywhere in the United States where there is no hospital, it's a third world country there. So you don't have to go far. Maybe I blew your guys' minds in just those first couple of slides. And so my story, I already told this. I did terrible in high school. I was smoking weed in high school. I was working full time, and not full time, but full time over the summer. I was just working towards like nowhere. I wasn't going anywhere fast, and it wasn't until I started community college that I got my act together, which means learning how to taste an A, learning how to focus, and taking it one step at a time. And I was breakdancing, hanging out. My senior project was on weightlifting. Like I was a total douchebag back then. Sorry for people that may have done projects on weightlifting. And so this is all the training I've done. So I've checked all the boxes. I've jumped through all the hoops. I've gone all the board certifications. And it was challenging. It wasn't easy. It was very challenging. And I'm trying to make these changes you'll see, because we're in a healthcare crisis, and we need anybody who is willing to help, who wants to be a physician and take care of patients and make those personal sacrifices. But you want to do it in the right way. This is a kid I saw in La Paz, and this is a girl we saw in La Paz. She drove 3 or 4 hours on a bus with her uncle to get surgery because she had an extra thumb. But I've seen the same here in the Central Valley. This is a 14 or 15-year-old kid who has been living with an extra thumb that hurts him. So it's causing him pain. He's living with an extra thumb. That's crazy. And so, as far as my trajectory, I was thinking about doing academics. I had help with patents and startups and basic science. But my trajectory was different. That's what was expected of me. And I knew that there was a need here in the Central Valley. And like I said, I was discouraged to come here. And so I didn't know how I was going to do it, but I was committed to doing it. And this is a story of a guy who saw a child without an arm and in Africa, and he's not even an engineer, but he figured out how to 3D print something to give him a potential prosthetic. And did he save his life? No, but he wanted to make an impact, and he had no business doing that, but he figured it out. And that's what you can do. And so I could have worked anywhere in the country, but I wanted to work here. And I've been here for the past 5 years. And I'm fortunate enough to receive this grant from California where they're actually paying off my medical school debt. And this is related to Medi-Cal. Patients with Medi-Cal, they will fund your loans. And so the other part that I like to talk about is social media. It's something I've always been involved in a little bit. And the reason why is that's where the public lives. And so there's a lot of, it's funny, there's so many plastic surgeons I know who are like, I don't want to do that. I don't want to do social media. And then they finish their residency and they're like, I have to do social media now to get patients. This is related to cosmetic surgery, right? And it's funny because, yeah, you can say you don't want to be part of it, but you're going to have a burner account, right? You're going to get your TikTok from a reel to Facebook. It's going to go through the ladder of social media, right? Or you're going to get it texted to you anyways, right? So my opinion is strongly, and this is pre-pandemic, I was talking, this is a slide from pre-pandemic, from July 2019, that this is a problem. If the physicians aren't there, there is going to be a problem. And we saw that with the COVID-19 pandemic. So I predicted that. And so I've always been involved in social media to show my path. And because I didn't see Latinos, I saw a lot of male and female no, physicians like modeling handbags on social media. And I'm like, what is this? This is not real. Like, what is going on here? Influencer doctors? That's not the case, you know? And so I do think it's important that there's people that are out there. And I think this Association for Healthcare Social Media, I don't think any much has come from it. And so, yeah, I believe physicians are part of the community, communicate with patients, help prevent misinformation. And so they have to be vocal, active, involved. And you'll see I'm not only an advocate, but I'm also an activist. And we know that diversity becomes important with clinical care. And there's so many barriers, and the social determinants of health become important. Um, and this underrepresentation of minorities becomes particularly important, and it's affecting certain patient populations. And I remember some institutions telling me, "Oh, we're diverse enough. We've diversified for all these different ways," which is great. But the question I always ask is, does the patient population match the physician population? And I do believe that diversity drives excellence. And there's a lot of data. I have pages of data, particularly related to the Latino patient populations, showing that cultural competence, language become really important. And this is the important mentorship. This is a student I met when I was at Berkeley. He was at in Moraga, what is it, St. Mary's College, and I met him at a Barnes and Noble. And I took him I took him under my wing because I saw him in the MCAT aisle at Barnes and Noble. That's where I would hang out, and I still do. I always get that chocolate chip chunk cookie. It's really good. You got to go get it warmed up. But I met him, and he ended up going to medical school. He ended up being a cardiologist, and now we work at the same hospital. And so I do think these mentorship opportunities really do help other students. And I've been able to give back. You know, this is back at Stanford. A lot of these are community college. Dr. Ron Garcia is a big proponent for community college students to join the healthcare workforce. And you see there's a lot of missteps that California has made. And I'm not even going into a lot of the details here, but there are a lot of mistakes. You know, let me give you a question. The Central Valley, there's 12 students at UCSF Fresno makes a year. 12. It's a joke. 12 students. I'm actually UCSF Fresno faculty. 12 students a year that they make. How is that going to make a difference for the entire Fresno population, you know? And for that reason, there's actually a private medical school. It's been in existence now for 4 years, and they're doing a good job. It's private, it's for profit. So students are coming out with a lot of debt. Yes, it's helping in the Central Valley, but those are the missteps, right? Like, why did that happen? What are these forces that allow this to happen? And great, that's fantastic. UC Merced broke ground, fantastic. You know, I think that's great. Let's wait like 6 or 7 years down the road, and I do think it'll make an impact in the long run. But we are so far behind. That school should have been built, 30 years ago. And so feel free to be outraged like myself. And so in regards to Latino patient populations in Fresno, for example, about 30 years ago, it used to be 25% Latino. Now it's about 60% Latino. And the state of California is predicted to be more than 50% Latino by the year 2050. And half the babies born are Latino. There's some outcomes, related to COVID, cancer, preventable diseases that are worse in Latino patient populations, and the language barrier being a big thing, and cultural barriers. And these are what I just said: undocumented status, chronic health conditions, and there's a shortage. Right now it's a little bit less than 7%, when the total population is 19%, but this will continue to increase. And so there really right now there isn't an expected change. There's an increase in the amount of students in the University of California systems. But if you look at the prime programs, which are supposed to help underserved students, they only make up 9% of the student body. And that's the question is like, really? 9%? Really? That's going to take care of our patient populations? 9%? And those are the questions that I really like asking. And I like being very vocal about it. Undergraduate mentorship is really important. You as pre-med students, outreach lectures that I've done are important to me. I've gone to Fresno State. We started a research fellowship here last year, but there's a much bigger level that needs to happen. And for some of those reasons that I just discussed, National Latino Physician Day was born. And the reason why is I wasn't seeing a significant change of Latinos in medical schools to meet the patient population. Small programs to increase diversity, DEI initiatives with no actual power to change, without any urgency. There was one faculty that was 3% Latino, which is nuts because some of their clinics can be more than 50% Latino, especially in the pediatric population. With Dr. Cesar Padilla, who's an obstetric gynecologist, he came up with this 6% is not enough. And we created this idea as a grassroots organization with the goal of including all the Latino groups and then major medical organizations, including Black, Asian, others, to create this urgency. And also, our next step is to alert the public, and those are our Latino patients. And so, this is the tweet from June 7th, 2022. It's time for a National Latino Physician Day. That's like my point of rage, as you can see, and as I talk, that when you get ignored, you make it happen. And so this is the first year the amount of organizations we had supportive of this day. This is the first year, 1,000 posts across the country, and some of our outcomes from that year. And then the following year, we had almost 90 plus organizations across the country. Really, really cool to see. But you can also see the dysfunction, the fact that the University of California, for example, like why aren't we getting this from all the University of Californias? Why aren't they talking to each other? They weren't. They don't talk to each other. They're different entities. And so that's where a grassroots movement is needed, especially when there's a lack of communication between major healthcare systems in the United States. And so you can watch this actually on our YouTube page for National Latino Physician Day. It is fantastic because all of these lectures are just powerhouses in their perspective on why this day is important and what changes need to happen, including calling for a Latino medical school, which is amazing, right? A medical school that is focused on Latino patient populations that obviously would be as inclusive as a historically Black college, but also considering things like language and culture, which in medical school, this is how much I had. And especially with a high Latino patient population, and even in residency. And so this is the day. This was fantastic. These are all leaders at Stanford. Dr. Elena Rios, Dr. Joaquin Arambola, he's an ER doctor here in the Central Valley, the dean of the medical school. And so a lot of leaders, and it was really a fantastic day. And those presentations were awesome. But this is the also awesome part is we were able to create these days. This is at a Union Valley physicians group at Santa Clara Valley. This is in San Jose, where they had a real live event day, a proclamation from the city, from the county, and then like news covering the day. And that is our goal, is to really create this urgency. Why do we not have enough of these providers? And you're going to see, even as because our physician workforce is currently getting worse. We're watching it get worse. And it's going to continue to worsen. And the minority perspective is going to be one of those highlights of things that are going to, in my opinion, it has to be addressed. And so this is Kaiser Permanente. This is across all the Kaiser Permanentes. We had a lecture that day. Here's at UC Riverside. They had a fantastic event. This is in Iowa. They had an in-person event as well. We sold 1,500 t-shirts, 40, it's actually like 60 pieces of TV and online media. and check out our website. This is a resolution in the Congress by two Latino physicians. It's going to be reintroduced this year. And then we got to this point this year where we were in discussions with the HELP Committee, Health, Education, Labor, and Pensions, a Senate committee led by Senator Bernie Sanders. And this is me having a meeting. I'm talking with him, with Bernie Sanders at Carl's Jr., because I was driving home from LA to the Central Valley. So I had to stop. My family's in the car, air conditioning on, with my wife, and I'm having a conversation with Bernie Sanders. And then the picture to the right is me practicing for my statement. And you can see the picture of Bernie Sanders that I drew on that Post-it. So I was like making sure that I can look at it. And so please check that out too. That's on my Instagram account, and you can also find it on the Help Committee website and also on National Latino Physician Day. But that statement of why this day is so important, and it really is a movement. And so the goal is to create awareness that 6% is not enough, to celebrate those doing the work, to encourage the next generation, which we're doing right now, in a supportive environment, and then highlight the ethical responsibility that institutions, hospitals, and medical schools have in increasing Latino physician representation for Latino population. Now, this helps everyone. Can you imagine like the cultural part? Can you imagine how the family part has been ignored in medicine? Isn't that insane? Think about that. The importance of familia in a Latino patient, in the culture of, imagine if that was actually part of medicine, if that was actually considered. The difference in wellness, the difference in life, work-life balance, all those aspects that have been traditionally ignored because, at least from our perspective, we haven't been included. And so that's where I do think there could be significant change. Now I'm going to talk about the need for diversity in surgical subspecialty and then mentorship tips. This is kind of a little bit higher end, but I think it's very helpful for you to hear. And so Cesar Padilla is texting me. He's always texting me. He won't leave me alone. So why can I speak on this topic? I'm underrepresented. I had awesome mentoring. I had mentoring from strong Asian, white, Indian, all ethnicities have mentored me to get to where I am. And it should be the same for every ethnicity. You don't necessarily, and I'll talk about that. You don't necessarily have to find someone who looks exactly like you. And I've been successful in my training. I was gaslit during training. I was told in my last year of fellowship, I was told, you're not good enough. You don't know how to explain a very basic diagnosis. I was treated very poorly. And I'm also an expert at this. I'm an expert in the physician workforce and in this topic of underrepresentation. And this is a book that I co-edited with Dr. Kevin Chung, who is our leader in plastic surgery. He is the editor of our main plastic surgery journal. And these are all new articles that we published about 2 years ago, related to the need to improve diversity in hand surgery. And there actually is a correlation, because in hand surgery, to have a good outcome, you don't just treat the bone. You don't just treat the skin. There's skin, tendon, bones, nerve, artery, all this tissue type, joints. You have to treat them all, and you have to be good at treating them all. And it really like hits the home about the importance of diversity to be good. To become a hand surgeon, you can either do plastic surgery or orthopedics, and you become board certified. But here's the issue. An orthopedic surgeon can do just a bunch of bone surgery and not know how to do microsurgery or take care of the soft tissues. And when they do hand surgery, guess what? They're not as good at that part. Or a plastic surgeon could be really, really good at the soft tissue and not be good with the bone part. You see what I mean? Like if you have diverse training, you actually become much better. And I was very I was very like for sure that when I trained, I wanted to do plastic surgery, but I wanted to be very comfortable with bone. And I went out of my way to do 2 orthopedic fellowships. And that's what I encourage others to do. That this is hand surgery and changes function, uses cool gadgets, changes form and anatomy. And it's a combination of plastic surgery, microsurgery, and orthopedics. And so we value the diversity of training. And similarly to that vein, is we should value the diversity of who we trained and who should reflect the patient population. And that's why we have this disparity. It took them 6 years to recruit me to come here to the Central Valley. 6 years where kids were unable to be taken care of. And they're medical orphans. They weren't able to see. Some of them, the kids that had higher socioeconomic background could get to Stanford, could get to LA, but some kids never left. And those are the disparities that happen when you don't consider these things. And so this is regarding these residency programs. Like ask those questions. Is the medical school diverse? Are the attendings diverse? Are the residents diverse? It's not the diversity of thought. And when you look at the trainees, the amount of Black and Hispanic and Latino surgeons has been stagnant at like 5%. And in hand surgery, it's been very low. The amount of women, too, has been very low. Gender diversity, 19% in hand surgery. This is data from several years ago. And so the reality is an underrepresented minority is unlikely to see somebody like them in their program. And that was true for me in my direct program. There was no Latino attendings in my program. And so I'm one of the few Latina pediatric hand surgeons in the United States. But there are 18 million Latino children in the country, almost 25% of children in the United States. And so that's crazy, you know. And this is the first Latina from Duke, an academic hand surgeon that I met. And then the secret for getting ahead is for residents again, but I think it's all relevant for you guys to hear is those specifically that come from underrepresented background is to get into hand surgery, which is a competitive field, and you can do with any field the same thing. You have to be strategic. You have to play your cards right. You need correct guidance. And then there's some residents that have advantages, which can be socioeconomic. They don't have to work, and then some of those that have a disadvantage. And so there is a call. We need more minorities in these subspecialties. And to be a good doctor, you don't have to be underrepresented in medicine to be a good doctor. That's obvious. Being a good doctor means being ethical and a true advocate for your patient, and especially for those that are underserved. And the way to get there is through mentorship. And this is where this mentorship versus sponsorship becomes important, because mentorship is somebody who actually cares and somebody who actually can guide you, somebody who's available for you to ask questions to. And sponsorship is the next level, where someone who writes you a letter of recommendation for medical school or grants you money to get you to your dream. And advice is something you have to be very careful with. You know, it's someone's opinion, and usually it can be without caring about the student. So advice can be good, advice can be bad, advice can help or hurt you. How do you know which advice to take? Is you need mentorship. You need advice from somebody who actually has an interest in you and doesn't have a conflict of interest. Let's say they're your boss. That's not a good mentor, because they want you to work, right? Your boss wants you to work. They don't want you to study, right? They can be like, oh, you want to go to medical school? Why don't you work here for a couple of years and then you'll be ready, right? There's a conflict of interest that people have. And so you need someone to see your story and to help guide you. And it's really intentional to help students. And then inspiration. I know pre-med CC has a very strong connection with Dr. Alfredo Quiñones Hinojosa. And for me, he was a true inspiration. I was a pre-med student at Berkeley. I saw him talk. I talked to him after, super inspired. But inspiration, and even myself, it doesn't replace mentorship. Like seeing somebody like, hey, I want to be that guy, or I want to do what they're doing. That doesn't like, that's like imagining in your mind that that person is helping you. And yes, they have a great story. Yes, they can inspire you, but you still need someone to help guide you, because you can quickly get lost. And so a surgeon mentor will forget what they did, and any mentor. So those that will mentor you, they'll say, and you'll see this, that they'll be like, oh, just work hard. You know, that's almost like gaslighting, because you're like, work hard, I am working hard, you know, and they may be too stressed out to a mentor that's too busy. And so you have to think about where people come from, and the challenges that they have. We're not all the same. Not all these animals can climb that tree, and equality and equity become important. But the reality is there's no one out here giving us these boxes, right? There's no one who's giving us these boxes. We have to like create those boxes. We have to find help to get on those things. And so the guidance that's needed for underrepresented and underserved students, is an important thing, and it's probably the most important thing with this trajectory goal, is that they need to ask for help. You have to ask for help. You can be doing the definition of insanity, which is, oh, I'm just going to take 2 more classes and work 30 hours a week, and I'm going to get 2 A's. And then you do that and you end up getting a C and a B. And then you do it next semester. You're like, you know, this time I'm actually going to do 2 classes and work 25 hours, you know, and then it ends up being the same thing. And the reality is what you need to do is you need to not work, right? That's what your mentor should tell you. You know what? You've been doing this. You need to focus on your coursework. You need to talk to your parents. You need to figure it out. You need to work for maybe a few months and then just take time off so you can focus on the class so you can get an A and then hit that trajectory. Taste that first A and then keep going up. And so that is where you need to ask for help and understand that there's different people with different socioeconomic backgrounds. When you guys sit in that same classroom with your other community college students, everyone is different. I remember there was kids that were privileged, there was kids that were unprivileged, there's kids that were never going to make it. The kids that needed to work full time, they weren't going to make it. They need to work full time. How are they going to compete? How are they going to catch up? They're not going to catch up. So you see it in your classes and you have to be very honest with yourself. What I actually do. And for medicine, it's not about how smart you are. I'm going to say that again. For medicine, it is not about how smart you are. It's about how you strategically play this game to get to where you want to go with mentorship. And so the world is unequal. Poor scores have no reflection to how smart someone is, more reflection on how they spent their time to study. None of this is hard. The content is easy. The quantity of content can be difficult, but it is possible. Surgery is not that hard. You can teach anyone to perform micro. You can teach a monkey how to perform microsurgery. You can teach people how to do surgery. And so now for general rules on mentorship, so in-person communication, I'm going to go through mentorship because it's important for you to see the other side too of what mentors are doing and that they're busy. So in-person communication is really important. Usually once a month is great. Everyone is busy. The relationship has boundaries, and mental health is an important consideration from both sides. I mentioned that the mentor does not need to look like the mentee. They can be different sex, ethnicity, political affiliation, socioeconomic background. All they need to do is care. That's all they need to do and not disregard. Not, yeah, I only have 1 minute. Let's go. And you want to facilitate a connection so you can find a mentor that looks like you. I think that is helpful though. But they may be too busy. There may be someone that is too busy to be inspirational. That can be inspirational, but they may be too busy and may not have enough time. And the other thing to know is a mentor doesn't need to stay with you forever. I have hundreds of mentors, people that I've met that have helped me for periods of times, and then I moved on for various reasons. It's not a lifelong commitment. And so you want to take something from these mentoring relationship, even if it's a fragment of knowledge that will make you a better person and physician. And what I tell students on how to get a mentor, it's to be cautious. You don't just randomly start asking, can you be my mentor? Can you be my mentor? You got to I think shadowing is important. Spend time with that person, see if it's a good fit. Set up a meeting at a reasonable time. Be mindful of that. Program directors is related to residency are too busy. You may have to look at in different departments. And then what I tell underrepresented minorities is you want to show up, be true to your word. Talk is talk, doing is doing, which just means you can say you want to do a specialty all you want, but you got to really ponerte las pilas. You got to put on your batteries and get ready, keep going, like the Energizer Bunny. And you always want to respond to an email that you get from a mentor. You don't want to lose that momentum, that opportunity. You want to be respectful, courteous, not intrusive, respect space, share your story. And then for the mentees, you get to decide what advice you should take. That's you as an adult, right? You can get all the advice, but you get to be the one to be like, I'm actually going to do this. And I've seen it. I've seen where I've given someone advice and it hasn't worked out. And that's hard. Those are learning opportunities for those people. And not to say that I'm always right, but I just predict that, again, if you have to work part-time and you have to take the MCAT and 75% of people are not working when they take the MCAT, and you're in the lower, and you're in that 25% that you have to work, you're going to have to be in the top 5% of smart people to get a really good score. You see how that math works out? Grit is an important component. You want to move forward and not run in circles. Always thank your mentor for their time. Always update them. They want to hear from you. And then for mentors too, the reason it's just good to hear this because they're human beings too. Never, ever put your mentor on a pedestal. They're just another human being trying to figure out how they're going. They're also living through their life their first time, right? So the mentors they should know that they're in a privileged place. They should not discourage. They shouldn't crush a mentee's dream. I've seen that in ER doctor that I was shadowing. I talk about this story all the time. She was so burnt out. She was burnt crispy. She told me I was shadowing. She's like, don't do this. This is terrible. You don't want to do this. This is not what I signed up for. And then I saw her like 15 years later, and she was still working in the ER, like seeing patients. And I was like, I wanted to call her out on it, but it's like, you like wanted to crush my dreams 15 years ago, and you're still doing it. That's very hypocritical. But there are people that are just not only burnt out, but just their personality, right? They're not someone who's going to motivate you. Um, Mentors should not have a conflict of interest. I think research is a big conflict of interest. A lot of people don't talk about this, but I think if your mentor is having you do research, they're not going to have you study for the MCAT, right? They're going to be they want you to do the research. Mentors should be available. They should answer their emails. There's a lot of emails I don't answer. I'm going to be very honest with you. It's not on purpose. I'm just running around and trying to catch up where I can and try to answer the phone. I can tell you from my own personal experience, I am not a perfect mentor. I do a lot of things at once, and so I'm actually not the best person to approach right now as I'm working on all these other things and have a full-time job. Um, Answer emails, and I'm not discouraging anyone to contact me. Please contact me with any questions, but it's just the reality. We have to be very like mindful of our time and what we can actually do. Um, Mentors should listen, don't overcommit themselves. And then when not to mentor, I think this is good. Mentors should know they shouldn't over mentor if they're overwhelmed with their practice. Like, for example, if there's challenges in your clinic or there's things that aren't working well in your hospital, you probably shouldn't be mentoring at that point. If you're overwhelmed with your home life, your kid's going through something, if you have too many things on your plate, if you have a substance abuse problem, if you're constantly negative or jaded, it's better not to mentor. And so it's pretty funny. Like, I think when mentorship programs start up, they're like, who wants a mentor? Who wants a mentor? Who wants a mentor? And they just get people, like, right? They collect people. But there's really not everybody should mentor. And then you should have an expectation. This may work, this may not work, and have at least some respect and learn from each other. And then there's also the anti-mentor. So someone that you do not want to be like. I have like 5 of these. I'm not going to name them, and I can think of them. These are doctors that I've met that I'm like, I never want to be like you. You're not a good doctor, meaning I may have red flags from like poor follow-up, not wanting to. I had one guy who literally didn't want to see a patient because they spoke Spanish. And they're like, Dr. Galvez, why don't you go see this patient? Um, it's racist. And so there may be things that you don't like about them, personal attributes, how they treat people, but you should learn from that experience anyways. I think it's really important to see that you can learn the type of doctor that you want to be. Um, and then help them get out of the situation. No, this is related to like if you see somebody in this situation, you got to get them out. You can't let them, and I think the mentor should be called out on it, but I don't think that happens, honestly. And that's a cultural problem in medicine. How do you approach the mentorship relationship if you do not click with each mentor and mentee? So sometimes you have to walk away, but try not to ghost somebody. But this is such is life. Things may not work out. Um, and yeah, and if things are not getting along with anyone, then it may be a good time to look within, and there may be a mental health component too, that could be contributing. So examples of good advice and encouragement: prepare for your, this is related to surgery, but again, anybody can listen. Prepare for your cases, study for your tests, do your research, find protected space so you don't have distractions, come up with a good backup plan. Bad advice. This is good for you to hear. Bad advice. Oh, just study MCAT exam crackers. That's what I did. Or I just did a Kaplan course. Just do that. Just apply to 10 medical schools. I did that 30 years ago. I've seen students do that. I've seen students apply to 10 medical schools. I'm like, who gave you this advice? I get that, like, you're hopeful that you're going to get into a California school, for example, but like your mentor didn't actually look at your entire application and say, this is probably you need to apply more broadly, or you're wasting your time, everyone's time, your entire year. And then I have my personal statement and application is on my website, michaelgalvezmd.com. Um, Another bad advice: don't worry about backup plans. That's what I did. No, you should always have a backup plan. Your personal statement is fine, just means that they didn't read it. Just take a year off. for research without considering the socioeconomic challenges. This is related to getting into competitive residencies. Oh, I matched, just apply and it'll work out. And so that's where this trajectory thing comes forward. And so you got to move forward with mentors. And so every single step, I can name them. Um, Dr. Mattern at community college, he was a biology teacher, who treated me with a lot of respect and thought that I could achieve a lot. I sent him links about the Senate committee hearing, so he can watch it, so he can promote it at DBC for people to see. At Berkeley, that was way challenging. I had to find outside mentors. I didn't find a single mentor. Dr. Alex Zaragoza, a Latino professor, but besides that, like none of the science courses. UCSF, I had a really strong research mentor, fantastic. Hal Chapman was his name. He took me under his wing. He was great. I'm in Tech Amarjeet, medical school, plastic surgery, tons of mentors, fellowships, and even at my current job. And so how many mentors have I had? A lot, probably about 50 unique people. And Dr. Amarjeet Dosanjh was the one that took me under his wing when I got rejected to Stanford initially. He told me, why don't you just send an appeal letter? And I ended up sending an appeal letter and I ended up getting in because I was doing research and I matched kind of what Stanford wants. And then in regards to the underserved UIM student, like it's important to want to give back. DEI stuff is what I call it. That's not true though. You know what I mean? It's like outreach clinics or health fairs, for example. You want to do that. What do not tax them means is related to residency programs, but you don't want, like sometimes because you're a minority, they're like, why don't you run this minority thing, right? And you're like, wait, I actually should be studying instead of running this thing. And so in regards to those students, there's some that aren't involved that don't care. And those are privileged students, meaning they come from money. That's a fact. They're not involved. They don't have, that's not a priority for them. And so they will act like a non-minority student, meaning they'll focus on school and they'll do well. And then there's some that are too involved. And that means they're president of AMSA of their school, they're founding this, they're doing that, they're working full time. And then they end up not doing well in school, honestly. And what you want to do is find balance and you got to ask for help and you want to get involved, but not too involved. And you want to focus on academics, tasting that A, making those small increments one by one. And there's going to be some blips, but the overall trajectory should be up. Being realistic with your time. And then other considerations, intersectionality. There's just different types of people. Life interrupted. This is Dr. Dingle talked about this. He's a African-American hand surgeon, but what can happen around the country, like a black male shooting can affect people profoundly and taking a break. And then mental health, it's really, you don't just suck it up and keep going. Sometimes you do have to get help. So that's that part on mentorship. And I'm just going to talk about my practices. Hopefully it's a little bit fun too. So I'm helping build a program, all these different components to it. There's so many diagnoses in kids. It's crazy. My clinics are just nuts. In regards to different things that I get to see and explain. But I consider all the tissue. You want to maximize their function, their aesthetic, their family dynamic, social perception. You want to intervene at the right moment as a hand surgeon. I don't save lives, but I save function to hopefully live their life to the fullest. But there's all these barriers, as I mentioned, structural, cultural, financial, insurance, language. And the hope is that I can provide the best care here in the Central Valley. And so that's me. Part of the plastic surgery team. And then this is like my overall team, where we have a nurse practitioner who I operate with, a nurse navigator in clinic who helps us coordinate care, a social worker who connects the families, hand therapist that ensures that they get good outcomes after surgery because they have to move. And this is us with a therapist here. And so the volume is just insane. I've done thousands of surgeries and affected a lot of lives one by one. And so this is a young girl with a myoplasia. It's this very, very unfortunate disease where the patient develops in utero, and I'm actually a developmental biology major too, but as the baby's developing in utero, the muscles and tendon and bone develop, but then for some reason the nerve, we don't know why, the nerves stop developing. And so since the nerves stop developing, the muscles contract in. And so they don't have a normal nervous function to their hands. And so this girl lives with her hands flexed down. And so what I had to do, I actually did one 2 weeks. This is from a couple of years ago, but I did one a couple of weeks ago. I actually have to cut into the carpal bones and cut some of the bones out to straighten and do a tendon lengthening. Kind of looks like Wolverine, but those metal pins hold things in place as things are healing. And so the hand is twisted, flexed down, but I'm able to straighten it out and then give the child more space to grab things with their thumb. And so this flexed in. They actually can't move their elbows. So the way that this patient eats is by using the knee. The knee is flexed up, and then they get their hand to their mouth. So they get active assistance from their lower extremities. And so we weren't going to, because she can feed herself with her right hand. If I straighten her hand, she won't be able to feed herself. So we leave that one flexed down. But the one on the left, she can now use. And this was a few weeks after her surgery. And so it looks like she's choking Barbie, but I don't think she's doing that. She's just holding Barbie to comb her hair. Um, and so pretty cool. But the other thing you should notice is she's not using her hand to comb Barbie's hair. She's using her feet. And so these are very just to be able to help a little bit is what I do sometimes. This is a patient with a thumb duplication, born with two thumbs. You can see that both of those thumbs aren't very good, but I have to figure out a way to combine the tendon, bones, skin to bring it all together to make it functional. A patient with aperts where the fingers are connected and doing skin grafts, separating them out. This patient will need a second surgery for those middle fingers. There's another syndactyly. And so this is the crazy thing is like if you do a good job, you have a good outcome. If you take time, if you're not in a hurry, you have a good outcome. And so that's what I've seen for my patients. And that's what's really interesting too, is like people are like research, research, we need research, we need research. You know what you need? You need to pay attention to your patient and you need to spend the time to do a good job. You need to connect the dots for them so that they get good care. That's more important. And unfortunately, the research part is what's it called? It's become a especially as you're applying to medical school as you get closer when you transfer. It does become an important part to trying to get into medical school and for residencies too. But it's hard to find those opportunities, and those opportunities are privileged, right? A Stanford University student rolls out of bed and he can be in a lab doing research. Like literally, that's the disparity, and that's the world we live in, unfortunately, and that's where you have to figure out how to get those opportunities. Hand trauma is something we take care of. This is a patient who had a really bad nerve injury, can't make a full fist because those nerves weren't working. So he can't pinch. He can't pinch at all. His thumb doesn't work. And so I did tendon transfers and muscle releases to get him to be able to pinch. And so that's a big deal from not being able to pinch on one hand to be able to use it. Here we put him to work outside. This is him drawing a dinosaur. I told him he needs to work on his dinosaurs. But he's a really good kid. He's like way older now. He's taller than me now, actually. This is a girl who presented with a nerve injury in an ER. They missed it. They missed the nerve injury. So the nerve was cut, and they're like, oh, you're good. But the nerve was cut, so the thumb wasn't working, so it required an exploration. And actually, if you put the hand underwater, the two fingers that didn't have nerve sensation to it, they don't wrinkle. It's very interesting. This is after reconstruction. I got nerves from the lower extremity, transplanted it to the upper arm, connected them, gave her time to grow, and then the nerve regrows. The muscle was able to get nerves back, and patient was able to palmarly abduct and use the hand, and now able to use that thumb in a much better way. And her wrinkling came back. She can be a raisin again in the pool. And then for microsurgery, transferring tissue from one place to the other. This is one of the really skilled things that we do as plastic surgeons. For kids, sometimes it's needed for trauma. ATVs are terrible things that cause kids harm all the time. This is the team that helped perform surgery. I got a muscle from the back and transplanted it to a leg. I didn't put all the gruesome images here, but there was exposed bone and all sorts of stuff that would have resulted in an infection and then an amputation. And so this is limb salvage, at least. This is after the recovery and patient was able to walk again. And so what I do too is I like to provide comprehensive care. It's when you see a surgeon, you typically just see the surgeon who has limited time is running around. But here I'm able to take a comprehensive approach. The child, the parent, ensure that both guardians are involved in the conversation for the decision. I have a nurse practitioner that helps me to evaluate the patient. I have a coordinator that coordinates studies so that when the patient follows up, the studies are done. I have a hand therapist that evaluates the patient after to help us decide what to do. We have a social worker, we have a child life specialist, we have psychologists as needed, and a conversation is had to what I see, what the treatment options are, and what they want. And this really should be the goal. Comprehensive care really should be the goal that we strive for in every clinic, rather than just running around with their head cut off. And so these are patients in clinic. This is the girl doing therapy. This is a girl with cerebral palsy. These are kids that we see. I remember seeing kids like this all the time. They have cerebral palsy. Their hands are twisted, flexed down towards their arm. And as a kid, you're like, I don't know what the difference is, but I remember them keeping kids like them separately in their special ed classes. And so it's really a privilege to be able to take care of some of these kids and try to fix some of these differences that they have. And so for this girl, her wrist is flexed down and her fingers are stuck down. And so I had to release the tendons for her fingers and actually put a plate to fix her arm. So she has a big plate back there. And so this is her 6 weeks after surgery, and she was smiling. Like her hand was where she wanted it to be. She had no control of it before, to where she wanted it to be. And so these are some of the most satisfying cases that we have to get kids better. This is a kid who had a brachial plexus injury. And brachial plexus means the nerves of the shoulder are injured during the birth process, the birth trauma. And so this kid, he's trying to get a cookie to his mouth, but he cannot. He can't get it to his mouth because his shoulder isn't properly working. And so like he switches hands, and he's had a cleft lip repair too. Um, and so there he is this is after surgery. He had a shoulder surgery that I did too. And shoulder surgery is typically an orthopedic surgeon, but guess what? I'm a comprehensive hand surgeon. Went out of my way to not only learn about the hand, but learn about the wrist, learn about the elbow, learn about the shoulder, so I can help the entire extremity. And that's, the difference is he's still kind of twisting his hand down, but he's able to get his hand to his mouth. And kids get a lot of crackers in my clinic, and Teddy Grahams. They get a lot of Teddy Grahams, the cinnamon ones. And so this is before. So when he tries to raise both of his arms up, this one doesn't elevate, and this is after. And so that makes a big difference for this kid in the long term. And you're preventing shoulder dysfunction in the long term too. I've done a lot of local outreach with our providers to try to connect people. Our goal is to connect and have kids taken here. And then we have the social media page, Valley Children's Hands, to try to educate patients. It's actually pretty funny. I'm like, oh, let me pull up my Instagram, and then I show them a video of whatever I talked about, and it's helpful. They're like, oh, I get it. I see the incision. Yeah, let's do that. That sounds good. And I think that's another important component, right? We have a culture too in America where, oh, your knee has arthritis. Let's book you for surgery. Okay, good. Everything went well. We'll do therapy. We'll see you later. Okay, bye. But they don't like show you the x-rays. They don't show you what the picture looked like. They don't show you what you did. And so that results in miscommunication. It results in people not respecting the work. And I think that's where patients don't get as good outcome when things are rushed and when it's like a factory type of setting rather than really trying to do an informed consent and trying to educate the patient. That's where your communication is so much more important. That's where I talk about this on social media. How you were raised is going to be the type of doctor you are, not your MCAT score. That's not going to tell you what type of doctor you're going to be. Everybody, I believe, is smart enough. I truly believe that. I think anyone can study and learn biology and memorize things and put out cards. And I do think if you want it enough, I think it is possible. But all I'm trying to say is I do think what type of doctor you're going to be is based on how you were raised and how much you care and how much you're going to check things off for somebody else and treat them like they're part of your family. And so this hand camp is for kids that meet other kids like them. We built that. And so we're trying to provide the best care here in the Central Valley. And so in summary, you can do what you want to do, but you have to come up with a plan and ask for help. That's it. That's all I got. Any questions?
Thank you, Dr. Galvez. This is the first one. Question from an attendee. Advice for seeking out mentors from health professions serving in the community as a pre-med college student. How do you look for that? That's the question.
Yes.
How do you seek them?
How do you seek mentors?
Yes.
So it's hard. It's hard. It's not easy. And it wasn't easy in 2000, meaning like you'd find somebody and they'd be, yeah, I'm too busy. Sorry. Bye. And so that's where it really, I think a personal connection makes it easier. I think I think you have to be assertive. Assertive is the word. It doesn't mean aggressive. It just means, like, let's say you're shadowing, let's say you're helping in an ER, like passing, like this is what I was doing. I was like passing out blankets and like juice, right? You're there, you're shadowing, you're helping move a patient. All of a sudden, you're helping a patient. Like for me, I was translating Spanish, for example, and then after helping to translate Spanish, which I get not everybody can do, but just as an example, if you're if you're within a patient's care at any point, what you can do is as the provider, whatever the provider is, APP, PA, nurse practitioner, or the physician, as they're walking away, say, "Excuse me, Dr. Galvez, I just have a quick question. I noticed you were talking with them, and I'm interested in medical school. I have a question. Like, do you think this patient is going to get an you think this patient's going to need, I'm just wondering, do you think is this patient going to surgery for whatever reason? You're not trying to get their healthcare information, but just like if you ask a thoughtful question that you're paying attention, that shows that person that you're paying attention, that you're interested in what's going on. And then as you're shadowing, you can continue to build a relationship and talk to whoever person. That's what I would do. And that's how I met Dr. Amarjit Dosanjh. He was a resident. I was like, oh, you're doing a hand procedure. Can I watch? And so I watched, I asked a few questions, and then I'm like, um, it's like asking someone out, when you're in high school. I'm like, can I have your email address so I can email you later? And so it does get a little bit creepy, but it's true. You have to be like open and assertive and say, can I, is there a way that I can email you my resume and my CV, and ask you more questions because I'm applying to medical school. And this guy was a boss. He would like look at my personal statement. He would give me advice. He would look at my secondaries. I still owe him, to be honest. So I think it's really hard. And I don't think there's a magic program that you sign up for that was going to magically connect you to this magical person who's both inspiring, perfect, and has the time for you. Am I making sense? There isn't a magic program like that. It doesn't exist because we're humans. We're all different. We all have different beliefs, uh, uh, availabilities. There's so many variabilities that I do think it's hard. And um, I do think it is a misstep in the United States healthcare system because I mean, the reason this nonprofit exists is because it has to be built. It has to be built. The government's not building it for us. They're not being like, hey, uh, pre-med students, community college students, you guys should be interested in medicine. No, we have to like we're seeing it. We know people have been successful. We have to build it on our own. We have to create these resources. And so I do think it's challenging. I think you really have to go above and beyond to figure things out. And I do think there could be better ways. Like, for example, I think, for example, in high school, and there's also problems, right? If you plug in a high school student who's not interested into a healthcare environment, that looks like a bored student, you know? And that's a waste of time. That's a waste of everyone's time. But if you screen somebody and you're like, what field are you interested? Are you interested in healthcare? And then you get them there early and you try to create a mentorship type of environment, you can create a switch for that person. But we don't have a systemic way of doing that. The reality is you have to make it yourself. And it's stupid. It doesn't make sense. We have a huge physician crisis. Why is this not being highlighted? And why isn't it being incentivized? Why is it so competitive, right? Like, why do some subspecialties make more money than other subspecialists that have gone to the same amount of school? It's just the whole system has a lot of issues, and that's why you want to be as educated as possible and learn about what you want to do.
Thank you. We have
Dr.
a
Galvez, can you stop sharing your screen so we could see your whole face?
Oh, am I scared? Am I sharing got it. Sorry.
Perfect.
we have a second question. Or what if one is not afforded the opportunity to not work and has to work full time to study the MCAT and take care of a sick parent? So what advice can you give to us who are in the struggle?
I think this is a really hard problem. I really do. And I wish that there was like government funding for things like this. If we have someone who's good capable, interested, wants to join us, we should be helping them. But instead, we're ignored. And those that are undergoing more socioeconomic issues are ignored. And that's the reality. And I think being very realistic with yourself becomes really important. And I was lucky. My parents were healthy for college, medical school, and residency. That is a blessing. I don't know why. I'm very grateful for it, but that doesn't happen to everybody, right? And if you have a sick parent, if you have a parent that has alcohol abuse, that really changes your home dynamics. You can't even go home because you're worried about your parent falling over drunk, for example. Like you don't have a safe space at home, and that's where I really do think it's important for people to be realistic in saying, I have this struggle going on. How am I going to strategize for myself to be successful? And I think the mistake that is made all too frequently is I'm just going to keep going, meaning I'm going to take 15 credits at community college. I'm going to work 20, instead of 30 hours, I'm going to work 25 hours, which is still a lot, right? And I'm going to take care of my sick parent. You can't do it. It's just not possible. You can do it, but you're not going to get the A's that you want, right? You're not going to be able to achieve that, even though you want to. I think a small percentage of people can do it. I think like 5% of people can do it. And so guess what happens is you end up doing that and you're like, I'm not good enough. I couldn't study. And that wasn't it at all. All you had to do was figure out a plan, which would be now is not a good time. My family is sick. I need to wait and see what happens, or I'm going to save up money for a period of time. I'm going to find scholarships and there really should be more assistance, in my opinion, for people that are interested and want to do the work but have a complex problem at home. And then the reality is you have to be very realistic. It's like you have to be realistic with yourself and what you can do, because I hate the definition of insanity is doing the same thing, right, and expecting a different result. And that happens to minority students all the time. And it always has to do with working a certain amount and no one else is working. No one else is working. When people are studying for the MCAT, they're not working. They're studying for the MCAT, right? And so if you're working and studying for the MCAT, your score is not going to be as high. That's a fact. That is a fact. And guess who's going to get a higher score is someone who's socioeconomically advantaged, someone who lives in a suburban neighborhood. Their parents don't bother them. They have a desk to study. They have no distractions. And that person will do better. And so it's really it's really, really challenging discussions. And that's where I recommend talking to your local mentor and someone who is going to care enough and be truthful with your situation and give you a potential plan, but you have to realize your limitations. Um, yeah, I think these are hard questions, and I can't solve that. I can't be like, what do I do? Like, oh, just do it. Just do it. Work hard. Just study hard. You'll figure it out. No, it's hard. It's really hard, and I think that's where you may have to take a break. And it is, yeah, I'd love if anyone else can chime in, but those are my thoughts.
I definitely agree with you, but I also think that probably manage the expectation, maybe taking a little bit longer time to prepare for MCAT instead of others who took only like 2 to 3 months. So manage the
I
expectation.
studied for the MCAT twice. I got a low verbal score. I know it's different now, but I had to take it twice over the setting of 1 year.
Yeah. So we have a few more questions as I'll speed
Please.
up a little bit. How many schools do you recommend to apply to?
I don't think I'm the best person to ask. I haven't applied to medical school in 24 years, you know? And those are things like you don't know yet, but you'll get to know is the amount of students that I mentor through to get into medical school has and it's because of the work that I do and the National Latino Physician Day. I just don't I don't have that information. I don't have the latest information of saying how many you should apply to. All I know is 10 is not enough, is what I'm trying to say. But that's where you have to figure out how much money you have, how much you can afford. And this is crazy. It's all money. Did you know when you graduate medical school, the average person to like interview, I think it's like $7,000 to $10,000 or something like that. That's how much money you have to spend. I got out a credit card. Sorry, I got a loan, a loan to apply to residency in medical school. And I was in credit card debt when I finished residency, about $30,000 in credit card debt. And it was honestly, Stanford didn't pay enough. It's totally crazy. They just literally didn't pay enough. And underpaid in an area that costs a lot. And that's where you have to make these decisions. I'm being honest, like these are the socioeconomic decisions you have to make. Should I be living in like a hipster, cool place where I'm paying a lot for rent? Or should I be living at home? Or should I be living somewhere that's more reasonable? You know, should I have subscriptions to Hulu, Netflix, Apple, Disney Plus, HBO Max? Should I have all those? Or should I just get one and then share my password with somebody else? I'm just kidding. But like, those are the real decisions, monetary decisions that you have to make to figure it out. Because otherwise it will catch up to you. And we don't all have these magic resources. Some of us do, though, and it's a privilege. And that's why we have these socioeconomic disparities. We're lacking of people that really, 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 really care. And I do think minority populations, us with a lower socioeconomic background, I do think we really, 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 really care. But we really, really, really need dinero. We really, really need ways to lift us up. But where does that come from? And it doesn't exist. And it still doesn't exist. And that's what National Latino Physician Day is about too, is we're trying to advocate for these changes. And it doesn't just have to be with Latinos. Like we have to have a better system that considers some of these important challenges. It's not, and that's where you get some people, oh, you're not qualified. You didn't study enough for the MCAT. You're like, what? I've been working 25 hours. That's why I didn't get enough. That's why my MCAT score is not the same. But do you think admissions actually looks at that? They don't. They don't care. They're just trying to weed through things. So you have to strategize.
So there's a very related question. So knowing that there is a shortage of physicians overall and underrepresented minorities, why are medical schools not adjusting? For example,
great question. If I was in charge of policy, and the reality is you have these major $1 million corporations with conflicts of interest that release the data that let me give you an example. There's so many problems like pediatric dermatology. Guess how many pediatric dermatologists we have here in the Central Valley? Zero.
Wow.
So why isn't there someone and we have kids here that have pediatric problems that need a pediatric dermatologist, but we don't have anybody here, for example. And so those are the questions that I have is like, why, if we're making dermatologists, why aren't we ensuring that they're covering all the parts of the state, right? Why? Why don't we have that? Why are we ignoring these subspecialties? A hand surgeon, if you blow off, I was on the Telemundo in Espanol. I was like, and I told this in Spanish, I was like, if you blow off your fingers, you don't know what hospital you're going to go to because you could show up in the Central Valley and blowing off your fingers is kind of an extreme. Usually there's not much to do because it's all blown up, but like sometimes you can put the finger back on, right? But in the Central Valley, there's no one to put your finger back on. So you have to go to Stanford or LA. You have to travel 3 hours, helicopter. That's expensive. And so like those questions of like how physicians are dispersed, it doesn't exist. It doesn't exist in the United States because we don't have a healthcare system that wants that. We have a healthcare system that's a business model and an insurance model. And so that's why there's a shortage of physicians. And why are the medical schools not adjusting? Stanford Medical School. I'm going to call Stanford out right now. I think they still have 90 medical students. They had 90 medical students when I was in medical school in 2006. Why is that? Why is that? And maybe they have 100 now. Like they have like literally like 4 or 5 more or something crazy like that. Why is Stanford ignored? How do they get that privilege to say, you know what? We're the best. We're the best medical school. We have researchers. We do academics. We're world renowned. How are you helping, sir? You know, how do you care enough, sir? And that's it. And meanwhile, we have medical schools that are opening up that are for profit, for profit. You're going to go into medical school and you're going to come out in debt. Are you going to be competitive for a subspecialty to get yourself out of that debt? No, you're not. It's going to take you years to get out of that debt. And I'm not trying to discourage you. It's just you have to be realistic with these challenges and know that it's not just how good you are. It's not. It's not how you could be very qualified to be a doctor, a very good doctor, studious, knowledgeable, the best attention to detail, but then stuck in the system where you have to go to you may have gotten, you may not have had a high enough MCAT, and you have to go to this DO school that's going to be more expensive, and you don't have another option. But you got, you're going to go, you're going to become a doctor. It's going to be fantastic, but like, is that your fault that you have to do that? No, that's not your fault. It's there has been a failure, in our opinion. That's what we talk about all the time with National Latino Physician Day. There is a failure in our medical school systems where we have 12 students come out of the Central Valley from the UC system, and now we have a private medical school. Why is that? Those are the questions. Why is that? And so when you ask, why don't medical schools adjust? They are trying to, and some are trying to, but they have not met the moment where you're telling me I'm attacking the University of California, and I do this all the time. When you're telling me the University of California only has 9% of people in this prime program to help underserved students, 9%, how is that going to meet our patient populations, right? How is that? It's not. It's not, because we're behind, and we're still behind, and there still hasn't been a drastic change. But don't worry, UC Davis is very diverse. They're super diverse. Look at UC Davis. They're super diverse, UC Davis. What about the other ones, right? That's crazy. Those are the questions that we have, that I have. And that's where you have this bias for research, for academics. That's when you get people in charge that care more about a research paper than care more about taking care of the local communities of California. Remember, I was discouraged to come here, right? I was discouraged to take care of kids here. And so that's where, as you go forward, the more knowledge you have, the better armed you are, the better, like myself, you can understand and agree that it doesn't make sense. You know what happens sometimes? Some people go into medical school and they're like, I didn't know this was going to happen. I didn't know I'd have to document all this stuff. I didn't know I'd have to work so hard. No, you as a pre-med student, as you shadow, you can see and you can learn a lot. And that's what I did as a pre-med student. I was shadowing, I was learning what I wanted to do, what I didn't want to do. Even in the ER, I was like, I could do this, but I don't really want to do this. I want to do something else. And I'm not talking against ER. I think it's a great field, but that's where, as a pre-med student, you actually have a lot to learn, a lot to take in. And you don't have to fix. And another thing to know is you don't have to fix these systemic problems. You don't. The reason I talk about them is just so you are aware and you understand that you are valuable, needed, competent. Te necesitamos más, whether Latino or not Latino, your background, if underserved, particularly, like I do believe that community college students, and take a look at this. We have an article in Scientific American too, with me and Dr. Padilla, that talks about the need to increase more community college students. It increases it because there's more Latino students in community colleges. It increases Latino students too, but it's the same thing. It's like community college students come from working class, underserved, will care more, rather than, let me give you an example. Let me give you an example of something that's important to hear too, is when we think about who we're training, when I think about a Latino, even Latino, like whether Latino or not Latino, like there was another underserved medical student at my medical school who was like, you know what? I want to do dermatology and I want to make a lot of money. That's what he said. He said, I want to be a dermatologist and I want to make money. And guess what he does right now? That's what he does. He does dermatology and he makes a lot of money. Does he take care of underserved patients? Probably not. as a private practice dermatologist. But that's where those questions come into play. And what we've done is created a system that rather than saying, hey, let's create a pediatric hand surgeon that's going to stay here in the Central Valley, let's build it from here. What's happened instead is it's a free market system of whoever gets to choose. But that's where I think there needs to be more organization from the top. I can
Gotcha.
go on rants, as you guys can see.
Just a quick time check. How much time do you still have? Because we have like a couple.
Yeah, I can go through the questions quickly.
Sure. If the doctor told you to see the Spanish-speaking patient, is it possible that he said that in order for the patient to have better quality experience with you as a Spanish-speaking doctor, rather than
Oh, great question.
later?
Yeah, so no, in this instance, he specifically said, that he didn't want to see the patient, and you speak Spanish anyways, just go see the patient. And it wasn't, it was more of like, please don't disturb me. I'm too busy, and may or may not have been racist, but in that instant, I was like very taken aback because it was clear that he didn't not want to see this patient because he could not be disturbed to find a translator or to speak Spanish, etc. But it is a good point. I didn't interview him after about it, but it's just those are the things that you see. And language is ignored. We talk about this all the time. Language has been ignored. Language allows me, and I encourage everyone to learn Spanish and medical Spanish and to teach and educate yourself, especially if you're going to stay in the state of California. In fact, we were National Latino Physician Day helped with this bill for physicians to take continuing medical education to learn language. So that hasn't happened before. But rather than I do think, and I've personally known physicians that have had their entire career, decades, working in a Spanish speaking community and haven't learned Spanish. And that's where the systems have to kind of realign and like, should we be teaching physicians a language? Should we be giving them time? Should we be sending them in an immersion program? And obviously they have to be comfortable, competent, able. There's a lot of barriers to language. But I do think it's been ignored. Why has it been ignored? It's completely ignored. And the reality is as I can knock through the door and I go from an English speaking to a Spanish speaking, you're more efficient. You connect more. You can explain things at another level, and not just Latino. Anybody who speaks Spanish and is comfortable can really make a big impact and difference. And so I do encourage. You have enough things to do, but I just mean like it's something that really should be taught. And let me give you another example here in Fresno. The elementary schools don't teach Spanish. There's no immersion schools. Why is that? Whereas we have a large Latino and Spanish speaking population. And so it's a systemic problem. So it's not focusing on like, no, you can't be a good doctor because you don't speak Spanish. That's not it at all. But we have to ask those questions. You really do.
The other part of it too, in hospitals are now changing translators with iPads, so that has
100%.
a lot of errors. So that's kind of like at nighttime, you can't find a live translator. They give you an iPad. And it's like,
Yeah. And some of them are thinking that artificial intelligence is going to be able to explain a congenital hand difference, for example, like, or make somebody understand what a broken bone is. When I can't even explain it in English, right? When I tell someone it's broken, they're like, so is it fractured? Or when I tell them it's fractured, they're like, is it broken? Right? There's so many interchangeable words and ways to get misconstrued even in English that, yeah, there's a lot of problems. Artificial intelligence you need actual intelligence, everyone. Want me to I can run through these questions. Want me to do it?
sure.
Okay. How is medical school different from undergrad? Medical school is easier. Stanford Medical School was 10 times easier compared to UC Berkeley. Why? Because when I got quizzed on something, they taught me about it. And so when they taught me about it and I studied, I could do well. Whereas at Berkeley, they made stuff up. They pulled stuff out of their butt, crap that wasn't. I'll always talk about this test. I'll be fast because I hate it. They taught us 10 different ways on this physics test that this projectile shot up and hit a light. No, it didn't hit a light. It projected across the room and went into this bowl wherever you had to figure the trajectory. And it was in the book, it was in the homework, it was in the group session, all those three things. So you learned about that. You're like, I got it. I'm ready to go. And guess what? On the day on the test at UC Berkeley, there was a fan in the middle of the room. So the monkey hit the fan, getting shot out as a projectile, hits the fan and spins and then goes off. And like, where did that come from? And what does that have to do with anything in medicine? It doesn't. And the reality is, and at UC Davis, like maybe 3 or 4 years ago, there was an average test for a physics exam that was 60%. And you can imagine my blood was boiling at that point too, because that still happens. You still have these unreasonable tests at the University of California, at state schools, this is any school, right? But I just have these examples where you are you study, no matter how much you study, you may not be prepared. And it's scary, but there's really all you can do is study hard, do your office hours, take time, doing groups, get resources, do all you can. But that's the reality. It is challenging. And so medical school is way easier, in my opinion, because you're doing what you finally got to do. And those are the questions I have too, is like, why do we have these barriers within college? Could you tell us about a pivotal moment when you realized that your academic performance had to improve after high school? What was your first step? Great question. So I my girlfriend at the time had gotten into UC Berkeley. I think that was a moment where I was like, I can do this. I know she's smart. I feel like I'm smart. I'm going to try. I think that made a difference, like having a personal, knowing somebody closely and saying like, you are smart. I think I can be I think I'm as smart. And so I'm going to try to do this. That kind of got over a little bit of the imposter syndrome. And then I got a job working at a genome sequencing lab. And I just was motivated from that. I really liked that job, and I was like, I can do this science. I'm going to try to study, and I didn't realize it. I took advantage of the resources at my community college. Like for math, I wasn't good at math ever, but I went to the math office hours. I would try to do the homework. If I couldn't do it, I would have the tutor help me. Things like that. I just took advantage. And then when I got my first A, I was like, okay, this is what it takes. This is how much level of dedication it takes for me to get an A. And then I just kept repeating that formula. I got a book at Barnes and Noble. One was how to organize yourself, and then the other one was how to study. And so those, and I don't have those books anymore. I wish I did, but like any book like that can be very, very helpful. Oh, it's Modesta Garcia. Hey. And then if you were to redo undergraduate school, what would you have done differently during your journey to medical school? So yeah, I thought Berkeley was really, really hard. I kept it at that point. Again, I think my girlfriend at the time was there, and it was the best school. It was local, but I don't know if that was the best fit for me. I think I would have thrived elsewhere. I don't think you should shoot for the best school. I think you should shoot for the best fit. What advice would you give a pre-med student who is also interested in policy? Get a book on healthcare policy and start reading. Anybody can pick up a book about that and learn about single payer, learn about our current healthcare system, learn about Obamacare, and then you can talk about it actually. So if you educate yourself, you're not going to learn this in any class. You're not. They're not going to teach it to you in any class in undergraduate. But when you interview, you can talk about it. If you're like, I really dislike this healthcare system. And then they're going to be like, what do you don't like about it? And then you can be like, well, Obamacare did this and that. I think I'm talking about universal healthcare, but this is what I did. I was like, universal healthcare, I think having a single payer system would actually do this and that. And yeah, I would get some resistance, but I would be knowledgeable about it. And I think it's good. What advice would you give a pre-med student who's also interested in reopening of Madeira?
Yeah.
Yeah, they're reopening it. I'm glad that that's happening. I think that's a huge, we've had impact at this hospital from that hospital closing.
But the other part of it too, I would just say is there's a lot of local elected officials that need staff. And most of those jobs are part-time. So if you can find a job working in one of those places, that's one of the also best ways to do policy work.
I just told everybody to study.
I know, but if you have to work
jobs.
10 hours a week, it's a good experience. I mean,
it is a good experience. It is a good experience. I don't think,
but not at the expense of your grades.
Yeah. How do you differentiate yourself and talk about your difficult background to medical schools during the interviews? Or should you just focus and be your own personality? I think you should talk about your challenges. I think there's always challenges. I think they're different for everybody. I think it's better to open up about them, even personal things, like I think saying my parent was an alcoholic and it was really hard when I was a kid, like that's a really personal thing, but it really makes when you're telling your story, it can help kind of frame where you came from, and I think different, like my story is the same. It's the truth. My story is the same. My parents were Peru. They came from Lima. I grew up without health insurance, but fortunately, my grandparents were able to take care of me when I was a kid, which is a privilege, in my opinion. And not a lot of Latinos get that privilege of knowing a family member who was in medicine. And though he didn't practice here, I still knew that I could do it. Anyways, just I agree. I think yeah, I think differentiating is just telling your story. And I have some YouTube videos on telling your story on my YouTube. What made you continue striving despite being discouraged? What did you realize you wanted to be a pediatric cancer surgeon? So I was discouraged even in that fellowship, like I mentioned, where I was told I wasn't really good enough. And so I think I think when you enter the room and you're with a patient and for me, it's language as an easy way to realize that you're very qualified. And I think it really is that ability. Your ability to communicate as a physician is the most important thing. It really is. And so I encourage you, whether, I think I just told somebody, yeah, I just told somebody recently they need to get a regular job. That's what I told somebody recently. They had worked with their family their entire life, under their dad doing some type of work. And I was like, dude, you need to like work at I worked at Togo's, I worked at Banana Republic, customer service, right? I mean, I was able to communicate and like, oh, I'll go grab your shoes. I'll grab, this different size, like I customer service. And that made, I mean, Togo's wasn't really customer service. I was just making sandwiches, but like talking to people and communicating, I think you need those real life experiences to become a better doctor. What did you do for
And I
clinical
could
out?
say, oh, and I could say just knowing Dr. Galvez, he's very persistent, and there was no quit in him. So, and he takes that discouragement as fuel. So,
Yeah,
and
no,
being
that's fair.
persistent, and that's something I'm just gonna add about you. But
Yeah, that's fair. What did you do for clinical hours, EMT, CNA? So it was different back then. I just shadowed. I just was shadowing I had shadowing hours at San Francisco General Hospital. And so I had shadowed at John Muir, but I grew up without health insurance. I didn't know what it was like to be in the hospital or clinic. And so when I shadowed at John Muir, I was handing out blankets and juice. And I was like, this is worthless. I'm not learning anything about what it's like to be a doctor. And so then I commuted to San Francisco General Hospital, where I was irrigating open wounds. I was like talking to the homeless patients. I was translating Spanish. They had this program where you could assist a little bit more. And so that's where I got clinical experience. And that's what I recommend for anybody, is to try to find real hands-on things, rather than like moving one patient to another. You want to find things that you can actually be helpful and useful. And that may be in a more underserved population where there's more opportunities to do more things rather than sit at a desk.
yeah, and you don't have to go far to find those facilities in your community. You don't have to go on a 2 week trip to Mexico, or there's a lot of communities that are really close to you that really need that are underserved. So it's not, it's not that far. And we don't live in your community, so it's kind of hard for us to say this is where you should go. But Dr. Galvez is just talking about his experience where he lived at the time.
Any other questions from anybody?
No,
Thank you
I
so
think
much.
we kept you longer, and sorry for the challenges to starting late.
And yeah, no worries. Thank you
Thank
for
you
having me.
again. Thank you again for coming, Dr. Galvez.